Okay, thank you, the host, and I'm so honored to have this opportunity to share with all the overseas orthodontists with our knowledge and the clinical experience about the new appliance we use for the last decade to treat this kind of severe Schedule Class 2 patient. So it's okay now? So my name is Xu Ziqing, it's Chinese name, and my topic is about clear orthopedic appliance SASGTB in correcting severe class 2 jaw discrepancy. And I work in Shanghai, China, and Shanghai Taikang Bible Dental Hospital. Actually, I'm on behalf of this huge group, and you can see in the middle one, this gentleman, and he is also my boss. And this one, and he's the leader and also the pioneer of the whole philosophy and treatment mechanism and all the appliance. And he's the real hero. And Dr. Shen got his master degree in 1991 in Shanghai and the medical university, and got his PhD in Hong Kong U in 2000. And then he worked as the head of Department of Orthodontics in Shanghai Nan's Hospital, which is also the top 3 dental hospital in the whole China. And then he worked as a professor in University of Sydney for 4 years. And after that period of time, he come back to China and work as the chairman of the Department of Orthodontics in Shanghai Jiaotong University, and also the vice dean of the dental school. And at that time, I followed the Dr. Shen and started my orthodontic career. And in 2016, we moved from Shanghai Nan's Hospital, the government hospital, to a private one, to Shanghai Taikang Bible Dental Hospital, which is also the largest DSO dental group in the whole China. So if you guys have any opportunity to visit Shanghai, please come to our hospital. It's in the real center of Shanghai. So this is my career of following Dr. Shen to study my orthodontic experience. And I finished my master's degree in 2011 and get my PhD in 2016. And I also work as a original member in developing this new clear version of SGTB. We call it S8. So this is the content of my lecture today, and we have the 3 topics. What is Smartee SASGTB, and what is the indication of this appliance, and how SASGTB works? And actually, we have the whole day lecture if we have if you have enough time in the future. So it will cover all these aspects of this appliance, but we only have 1 hour this evening, so I'm trying to finish all the 3 topics to you guys. So what is SASGTB? This is the origin of the SASGTB, the fixed twin block appliance. We call it SGTB, Sagittal Guidance Twin Block. So we have used this kind of appliance for many, many years, for like 100,000 patients already treated successfully in China. And then we also published many articles. We use this kind of appliance to fix very severe class 2, Schedule Class 2 patient. This is quite the typical patient. I will go very brief review of the patient. It's a 12 years old young boy, and you can see class 2 molar relationship climbed upper and lower incisors, and deep overjet and deep overbite has some space in the upper jaw. So this is typically a retruded mandible. So we can use this bonded SGTB to move the mandible forward. And after the stable position of the mandible, we remove the appliance. We bond the braces, align the teeth, close the space, and close the gap between upper and lower in the buccal segment, and finish the case. So it's class 1 molar, class 1 facial profile. So everything get perfect. So it's quite typical case we treat with this kind of fixed or traditional SGTB to treat this kind of class 2 patient. But this kind of traditional fixed SGTB has many disadvantages, like its lack of aesthetics. In our clinic, we have many adult patients, especially young ladies. They worry about this kind of bulky red plastic we put in the mouth. They don't want this. They want a very aesthetic treatment. And also the oral hygiene. You can imagine when the patient wears this kind of appliance, it's a huge bulky appliance, it's quite impossible for them to clean the teeth perfectly, especially for the teenagers. And also lack the efficiency. That means if you want to align the upper jaw, the upper dentition, that's possible because we can have some expansion for this upper piece, and we can align the frontal teeth of the upper of the maxilla dentition. But it's impossible to expand or align the lower dentition when we use the kind of appliance because the lower piece is removable. We have some add-on clamps and the ball clamps. It's a removable one, so it's lack of efficiency. And also, when we remove this kind of appliance, especially in the upper one, we will get very huge gap between upper and lower buccal segment. It's open by the buccal segment. So it's very inconvenient, it's very uncomfortable for the patient when we remove this appliance. And also it's very inconvenient to do that. So we want to make a new version of SGTB. So we will take a full advantage of the clear aligner. So we make this. Actually, we start to use this kind of a new appliance since 2013. So it's like 10 years ago. So why we call it S8 is like a number. 8 in China is lucky number. So SGTB means sagittal guidance twin block. So it's a new version of SGTB. And we got anatomic occlusal splines and also locking appliance in lower and both upper and lower. So interactive surface will maintain the maintain the forward position of the mandible. So we like lock the mandible in the forward position. So this is the SASGB in vitro and vivo. So the next topic is what is the indication of SASGTB? So before we start this, talk about the indication, we want to introduce the new diagnostics classification proposed by Professor Gang Shen. So he's really a brilliant guy who invents or who proposed a new classification. Everyone knows in the past we use angle classification, but the pitfall of the angle classification is we only describe the molar relationship in angle classification. We don't have any other occlusion, other information like the etiology of the malocclusion or the dental facial deformity and the treatment plan and any other skeletal problem. So we can just describe the molar relationship, use the old traditional angle classification. But Professor Gang Shen want to provide or propose a new classification which can divide and which can reveal the etiology of the malocclusion, the etiology of the dental facial deformity, and even we want to help every orthodontist to make the right or proper decision treatment plan for the treatment. So just like these two pictures, we can see the protrusion of the maxilla and the retruded mandible, the lack of the trim prominence. But can you imagine beneath the soft tissue, what can we get? We can have, it's quite similar soft tissue facial profile, but beneath the soft tissue, we can see it's a huge open by horizontal hole open by the left one and deep curve speed in the right one. So the etiology and the treatment plan of these two kind of patients is totally different. So how can we use just one classification, class 2, angle class 2 classification for this kind of treatment? So it cannot provide any information. So Professor Gang Shen, he tried to have the new classification and diagnostic classification. So we divide it to three types: the facial prognathism, the facial reconnaissance, and the facial asymmetry. It's three types of the new classification. So today we want to focus on the facial prognathism. So facial prognathism, we have five different types. So I will go very briefly of these five types. The first one is dental alveolar originated. So why we call it dental alveolar originated? That means for this kind of patient, the morphology and the position of the upper and lower jaw is normal. The jaw is normal, so relationship is normal, and the morphology is normal, the size is normal. But because of the crowding, maybe lack of the tension of the muscle of the lip muscle, the upper and lower teeth proclined, just like this animation. The teeth proclined, so that will produce the protrusion of the upper and lower lips. Maybe crowding, maybe some kind of the lack of lip tension. And also the molar relationship is still class 1. So for this kind of patient, the treatment protocol is simple. We can extract the teeth or no non-extraction. We can close the space with mini screw, maybe use a liner, maybe use the traditional appliance or lingual appliance. So the key is we want to balance the myofunctional. So we want to just retract the teeth. We put the upper and lower frontal teeth in the right position. The facial profile will get better. So it's just like a pure dental problem for the patient. So the next type is scatarly originated. So it's totally different, totally opposite kind of patient. That means for this kind of patient, the maxilla is overgrowth. So we can see the bulky alveolar bone. So because the maxilla is overgrowth, so it have enough space to accommodate all the teeth. So the frontal teeth is not proclined. It's very straight in the frontal area. It's very straight. And also the overgrowth of the maxilla will be like 3-dimension. It's not just like sagittally. It's about the vertical overgrowth of the maxilla. So we can see gummy smile when the patient smile. And also in the transverse dimension, if the overgrowth of the dental arch, the back teeth will like camouflaged, inclined palatally. So we can see the posterior teeth will palatally inclined. Still, we get class 1 molar. So it's kind of like this. It's overgrowth maxilla. So because of the overgrowth of maxilla and mandible, so we will get the protruding mandible. Also, we can have the vertical pattern of skeletal originate. That means if in the past we call the high angle patient, like the clockwise rotated mandible, it will cause increased lower facial third and the lack of the trim prominence. So this is another kind of skeletal originated pattern. So this is typically two different kinds of protrusion patients. The first one is dental alveolar originated, and the right one is skeletal originated. You can see it's quite different. The left one is just procondylar teeth. You can see the alveolum is very thick, but you can see in the right hand side, it's like bulky alveolar bone. So it's like it's a skeletal originated. So it's totally different. We can also see the gummy smile. You can see, if you see the combing CT, you can see the straight straight frontal teeth, and you can see thickness, the increased thickness of the alveolar bone. So it's very typical. So for this kind of patient, scatterly originated patient, the treatment protocol will be maybe surgery if the patient have very demanding, very high demanding of the aesthetic goal, we can use surgery. But if the patient refuse surgery, maybe we can have some extraction or non-extraction. But if we decide to extract the teeth for this kind of patient, the top control of the frontal and the vertical control, especially for the skeletal, for the vertical pattern, is so important. So in my clinic, I will use customized lingual system, which is like because we use a ribbon wire, arch wire, so it's brilliant in vertical control, and also the customized lingual system can provide perfect torque control in the frontal. But for this kind of patient, if we want to treat the kind of this patient with aligner extraction, it's a mess. It will cause the mess of both the occlusion and the facial profile. So this is the next type is we call the mandibular positioning originated. That means for the maxillar, the size and the morphology of the maxilla is normal, maybe proclined because of the lack of the train, lack of the tension of the lip, maybe crowding, but the lower jaw, the mandible is retreated. So that means that they have some jaw problem because of the lower jaw is retreated. So when the lower jaw is retreated, so what we will get in the dentition, then we will see deep overjet, deep overbite, and deep curve speed because it's a long-term camouflage by the patient. And also we can see class 2 molar relationship. So it's like typical intraoral photos of this kind of patient. And retreated mandible, but the upper frontal teeth may be proclined, but maybe sometimes we get space. So for this kind of patient, the treatment protocol, we can use S8 SGTB. So the fourth type will be combined scalary and mandibular positioning originated type subtype 1. So we have combined. So why we say it's combined? So it's combined the scalary originated maxillar and the mandible of mandibular positioning originated. So it's combined this kind of two type together. So, and we call it the subtype 1. So when we say it's combined subtype 1, that means the upper upper frontal teeth is straight. It's straight, but with the retreated mandible. So because the mandible is retreated, so still we can see 3 dips. That means 3 deep overjet, deep overbite, and deep curve speed. And also we can see the class 2 molar like this. So we can see very protruding maxillar and retreated mandible, and it's a cephalometric. So also this kind of patient, we recommend we can use SGTB to treat this kind of patient. So for the last type we call is combined subtype 2. So it's quite like class 2 division 2 in the past angle classification. We see the page like this. With the very much climbed up incisor. So for this kind of patient, sometimes the patient's lateral profile is camouflage. Why is camouflage? Because for this kind of patient, the lip tension is very strong. So it will force upper incisors move lingually, so it's retrocline. So the lip is not thick, it's very thin. And for this kind of patients, the trim prominence is also very good. So with very thin upper lip and the prominent chin, so the patient's lateral profile is acceptable. Even some kind of this kind of patient is beautiful profile. But still, if we want to know the etiology of this patient, that's because the mandibular retrusion. So we can still see three dips. That means deep over jet, deep over bite, deep curve speed. So this is so for this kind of patient, we also recommend we can use SA-SGTB to treat this kind of patient. So after we finish this 5 type, so we want to answer the question. So what's the indication of SA-SGTB? That means if you see any patient with mandibular position problem with mandible retrusion, that means mandible retrusion, we can use SA-SGTB to treat this kind of patient. For example, for all this case, and with the mandibular retrusion patient, we can see deep overjet, overbite, and deep curve speed. So in Chinese, we are say sanction, that means 3 dips. So if you guys see 3 dips in the mouth, you can imagine, you can just make a conclusion very briefly. That means the patient maybe have some problem with the jaw position. We can use SA-SGTB to correct this kind of patient. So I will show you some simple, some case very briefly like this. It's like more than 55 years old female. Deep overjet, deep overbite, class 2 molar, deep curve speed, crowding. And for this young lady also, you can see full unit class 2 molar, deep overjet, deep overbite, deep curve speed, and very protruded maxilla. And for this one, reclined upper incisor, we call it subtype 2. And for this gentleman, you can see full unit class 2, very protruded mandible, and gap space in the upper and narrow up dentation. So, and also for this one. So, and for this one, we already extracted 4 teeth, class 2 division 2 patient. So for all this kind of patient, what can we do if we don't use our new appliance? Maybe we can desalization from full unit class 2 to class 1. It's quite impossible if we want to desalize the like 6 millimeter for upper arch. It's quite impossible. So you want to extract the teeth, it's still very deep curve speed. Overjet and overbite, if you want to extraction, so maybe sometimes we will have some problem with the space closure. So you want surgery, but quite a few patients will accept the surgery, especially in China. Maybe for this class 2 division 2 patient, you want to proclination, the upper and lower incisor, but after you procline, the position of the lower jaw won't change, and we'll have a huge gap, a huge overjet and overbite, and then we can't solve the problem. But now we can use SA-SGTB to treat this kind of patient. We can use this appliance to move the mandible forward, and at the same time, we can align the teeth. This is the 50 years old female. You can see the treatment outcome. It's perfect. We can achieve class 1 molar. We can fix the overjet and overbite. We can make the facial profile better. You can see much younger. And for this patient, recline upper and lower incisor, we can improve the facial profile. And also for this gentleman, you can you imagine? It's like a surgery case. You move the mandible forward, make the occlusion better, make the facial profile better. All of these patients are adult patients. You can see also this one. So this is the indication of SA-SGTB. If you don't want to use this, the new diagnostic classification, if you just see deep overjet, deep overbite, deep curve speed, if you see class 2 molar relationship, if you see the patient maybe have some retrusive mandible, you can use SA-SGTB to treat this kind of patient without surgery, even without extraction. So what's more? So sometimes in China, we have many patients who will suffer from the condyle resorption due to the interference, maybe due to the very stressful. So like this kind of patient, 23 young lady, complain about the retrusive lower jaw and can't bite in the frontal. You can see the horizontal open bite. So this patient, why this kind of patient, we have the huge gap in the frontal, but we don't see 3 dips. We don't see deep overbite and deep curve speed. Because this kind of patient, he's like a pathological mandibular retrusion. That means the patient in the original position, the patient can bite in the class 1 position. So the frontal teeth can touch. But because the condyle has been resorpted, you can see very small condyle. You can see the condyle morphology is abnormal. Because the resorption of the condyle, so the lower jaw can move clockwise and downward and backward. But sometimes the patient want to bite, so still the mandible can still move forward to get the bite. So that we call it COCR discrepancy. So for this kind of patient, we won't see 3 dips. We won't see deep overjet, deep overbite, and deep curve speed. We can only see what? We can only see deep overjet, but a very shallow curve speed and shallow overbite, like this patient. So it's very typical condyle resorption patient. So still we can use SA, SGTB to treat this kind of patient. You can see it's very stable. And the patient facial profile and the occlusion has been improved a lot. And I will show you another case who suffer from the unilateral condyle resorption. And this poor young lady who just finished his orthodontic treatment, finished his orthodontic surgery. And this is what we get after surgery. You can see lower jaw shift to the left-hand side, class 1 molar on the right-hand side, class 2 molar on the left-hand side, and the increased overjet in the buccal segment here, and decreased overjet here. You can see the shifted midline. So what can we get after surgery? You can see the condyle on the left-hand side. It has been resorpted, and maybe it's resorpting now. So the patient is suffer from the unilateral pathological mandibular retrusion. So that's why the mandible moved left-hand side gradually. So what we do, we remove the braces, we put the appliance, and we fix the asymmetry. We move the mandible forward. At the same time, we correct the shifting midline. And we want to increase the space between the condyle and the fossa, so that will help us to stop the resorption of the condyle resorpting. You can see this is after phase 2. This is the whole treatment plan, the whole treatment. After the whole treatment, we achieve class 1 molar, and we correct the midline, and we give the patient the perfect occlusion. And you can see the smile, the facial profile. If you see the condyle morphology, you can see this one is before everything starts. It's before every treatment. And this is what we get when we receive the patient after surgery. You can see the condyle resorpting. And this is after the phase 1, after we move the mandible forward, use SA, SGTB. And this is after the whole treatment. You can see the change of the morphology of the condyle. And also we can make the 3D compensatory image. We make a 3D superimposition for this patient to check the condyle remodeling. You can see the inner morphology is before treatment, after surgery. The outer one you can see is after all the whole treatment. We get a new bone formation for the condyle. So what's more, we can use SASGB to treat. we can say many retreated, many extracted case. So all these extracted or retreated case are treated by SASGB. I just show you one case. It's definitely a surgery case. It's very severe. It's only 26 years old young gentleman. And he complained about the deep bite and chewing problem, snoring, and the patient has 4 teeth extracted already. You can see the facial profile, definitely a surgery case. And the patient just see many dentists and many orthodontists, and many orthodontic surgeons. Everyone want him to have a surgery, but the patient don't want to have surgery. So this is the intraoral photo. You can see the occlusion, the full unit class 2 for both sides, and the very severe deep bite in the frontal. You can see the curve speed. You can see the condyle has been resorpted, and you can see the periodontal condition. It's terrible. You can see the lower incisor has been impinged in the palatal tissue, and also the condyle. And you can see the periodontal condition. The alveolar bone is very thick. It's very thick. It's very thin. You can see. So the teeth just like in the, it has no support for both upper and lower incisors. So we made the mandibular advancement simulation for the patient. It's much better, right? So that means if you can successfully move the mandible forward, so it will help the patient have better airway and better facial profile. So this is a simulation, but you can see the huge gap. That why? Because the patient has very steep curve speed, so we have a huge gap in the buccal segment. So this is the animation. We use phase 1 treatment. You can see we try to align the lower curve speed, but quite impossible to align the lower dentition because the periodontal condition. And this is the patient where this SASGB appliance. It's a phase 1 treatment. So at that time, we want to close the open bite in the buccal segment. But if we just finish the patient with aligner, clear aligner, it will cost many time. So we talk about the patient, we may change to the fixed appliance to have some box elastics to make the open bite fix quickly. So the patient will bond the braces and put some box elastic in both sides to achieve the interdigitation. And we close the space, it's a finish. So can you imagine we use SASGB together with the braces, we can fix this patient. You can see the morphology of the condyle has been changed. You can see the lateral profile. You can see the curve speed has been flattened. And also the facial profile has been improved a lot. Still, it has some small change, but it's been nicer, right? So this is all the indication of SASGB. If you see we choose a mandible with 3 dips, that means deep overjet, deep overbite, deep curve speed, you can use SASGB. If you see the condyle resorption will cause the mandible move forward, you can use SASGB to fix it. If you treat some severe skeletal problem, the patient refuses surgery, you can use SASGB. So the next topic is how SASGB works, or the advantage of SASGB. So in one sentence, I will describe how SASGB works. Is SASGB moves teeth efficiently when reposition the mandible. We can have some alignment in the frontal teeth, both upper and lower expansion. We can have some interdigitation in the buccal segment. We can have some molar distalization, which is the best way of the clear aligner. So we will see the first, we can align and expansion during mandibular advancement. We can see the gentleman, young gentleman, is 11 years old boy, protrusive lips and snoring. You can see the upper dentition is narrow and crowded, and also crowding in the lower dentition, and deep overjet, deep overbite. You can see retruded mandible. So this is definitely the indication of the SASGTB. So for this kind of patient, we can expand the upper dentition and align the teeth with the space we created by the expansion. And also at the same time, we can expand the lower dentition and align the lower frontal teeth. You can see the outcome. You can see this is after the 10 months after the patient's phase 1 treatment, after we remove the mandible, after we move the mandible forward. You can see we have successfully aligned the both upper and lower dentition, and the dental, the arch form has been corrected from the sharp to a like rounded shape. And also we coordinate the dental arch, but still we have some space, gaps in the buccal teeth. So just 10 months, we can align the teeth, we can have some both upper and lower expansion. So it's more efficiently. You can see the facial profile has been changed a lot. So only in 16 months, the whole treatment finished. It's more efficient than the traditional SGTB. The whole treatment, you can see. The patient changed a lot. The smile, the facial profile, the mandible has been protruded, and also the airway has been opened. And the next one is about the occlusal settle down. So this is also very important and also the key advantage of SASGTB. Why it's so important? If we use the fix of traditional SGTB, when we when we remove the appliance, we will have a huge gap in the buccal segment. It's open bite in the buccal segment. So what can we do? We bond all the teeth with braces, and then we put some elastics in the buccal segment. So imagine if we put elastic in the buccal segment, it will elongate the buccal teeth, the posterior teeth. That will help to increase the lower facial third, and that will help to clockwise rotate the mandible. But the patient, if the patient is still a long facial third, it's like a vertical growth pattern patient, it's not favorable, right? So we want to control the vertical dimension, but we don't have any choice. But if we use SASGTB, we can close the buccal open bite by extrude the posterior teeth, or we can intrude anterior teeth, both upper and lower frontal teeth. So we can see this kind of animation. So if the patient is the average to high mandibular angle patient, it's like vertical growth pattern patient, we don't want to increase the lower facial third. We don't want to clockwise rotate the mandible. We don't want to increase the lower facial third. We don't want to extrude the posterior teeth. What can we do? We can have some intrusion of the frontal teeth, maybe the upper and lower. So if the patients just suffer from the gummy smile, we can intrude the upper frontal teeth more. And then after finish, the open bite of the posterior teeth closed automatically. For this kind of patient, you can see 35 years old female, class 2 molar relationship, deep overjet, deep overbite, recline upper incisor, and narrow up dentition and crowding. So for this patient, we want to move the patient mandible forward, but when we show the picture of the mandibular advancement simulation to the patient don't want this long face. He want to keep her lower facial third height. So what can we do? We don't want to extrude the posterior teeth. to close this open bite in the buccal segment. We can only intrude the lower frontal teeth because the patients, the incisor exposure, upper incisor exposure is perfect. So we don't want to intrude the upper frontal teeth. So this is what we do. We have some distalization, some expansion, some IPR in the frontal, and align the upper dentition, align the teeth. And at the same time, the most important is we maintain the thickness of the block of the posterior area. And at the same time, we intrude the lower frontal teeth to leveling the lower curve speed. We just intrude the lower frontal teeth. So let's see the progress of the patient. You can see the 3 months treatment in the phase 1. We align the frontal teeth and we intrude the lower frontal teeth. And the 5th month, you can see when the patient wear this appliance, still the open bite in the buccal segment, the thickness of block didn't change. And the 6 months, you can see after the patient removed the appliance, you can see the gap. You can see the open bite of the buccal segment has been closed gradually. And 8 months, you can see when the patient wearing this appliance, still is very open bite in the buccal segment. But if the patient remove the appliance, you can see almost no gap, just 1 millimeter gap, 1 millimeter open bite in the buccal segment. And the 12 months. So you can see after phase 1 treatment, the buccal teeth bite together, right? It's more efficient than the traditional SGTB. And you can see gradually 3 months, 4, 5 months, 8 months, and 12 months. Because we intrude lower frontal teeth, it will close open bite in the buccal segment gradually and automatically. So we only spend 14 months for this patient. We finish all the treatment. You can see more efficiently. So if it's a high average to low angle patient, we want to extrude the mandible. We want to increase the lower facial third. What can we do? We can gradually reduce the thickness of the block. It will help the eruption of the posterior teeth. And if it's not enough, maybe sometimes we use some attachment help to elongate or extrude the posterior teeth. Or you can put you can bond some lingual button, have some boss elastics to help to erupt the posterior teeth. I will show you my first clear SGTB case. It's in 10 years ago, before 10 years ago. It's an 11-year-old boy and his mother complained about the retruding mandible and the small chin and low facial third. You can see the malocclusion, you can see class 2 molar, deep overjet, deep overbite, and crowding. So for this patient, you can see the very retruded mandible and very small chin. So we want to increase the lower facial third and move the mandible forward. So what can we do? We can gradually reduce the thickness of the block. It will help the eruption of the posterior teeth. And at the same time, we align the teeth, we have some expansion, we align the lower teeth, and gradually make the interdigitation of the posterior teeth. You can see the first month, you can see still it's very thick. And the 3rd month, you can see the thickness of the block has been reduced. You can see gradually the open bite is closed. In the 4th month and the 7th month, you can see the 10th month, after almost we finish stage 1 treatment, you can see almost no block in the posterior area. So if we remove the appliance, you can see almost touch in the posterior teeth. And gradually we reduce the thickness of the appliance so we can close the open bite in the buccal segment for this kind of low angle patient. Only in 30 months, the treatment, the 13 months we finish this case, you can see the treatment, the facial the facial change. So the most important of the most brilliant advantage of the SASGB is molar digitalization. So it's also the great advantage of the clear aligner. I will show you one case, a 31 years old female. You can see the face. It's like a very plain facial area, you can see, and the small chin and the reduced lower facial third. But if we see the facial, if you will see the intraoral photo, you can see class 2 molar relationship, deep overjet, deep overbite, and crowding. So imagine for this kind of patient, what can we do? Is a deep overjet, deep overbite, full unit class 2 molar, crowding. For this kind of patient, do you want to extract any teeth? No, of course no, because the patient's lip is very thick. It's very thick, you can see. And if you want to digitalization of the molar, that's impossible because the 6 mm digitalization. Okay, we continue. It's okay. So what can we do with this kind of patient? It's quite complicated if you want to treat the kind of patient without surgery, without extraction, and without digitalization. So what can we do? You can see if we want to correct the overjet, deep overbite, and crowding, we can move the mandible forward. After we move the mandible forward, we can solve the deep overjet, deep overbite at the same time. And class 2 molar to class 1 molar. And at that time, we can have some expansion. We can digitalize the molar both up and lower. You can see we digitalize the molar both up and lower. And one thing I want to mention when we use this appliance to digitalize the molar is if we treat the patient with a traditional clear aligner, we want to digitalize the molar. When the patient remove the appliance, and when the patient biting and chewing, the force will cause the relapse of the digitalization. But when we wear this SASGTB, it's a huge open bite in the buccal segment. The teeth won't touch together, so it won't create the relapsing force for the digitalization of the molar. So you can see when we do some digitalization of the molar, when the patient wear SASGTB, the digitalization procedure is more efficiently. And I will show you the procedure of the patient. You can see both upper and lower second molar has been digitalized a lot. And this is the elimination, and this is what we get. You can see we start to digitalize the first molar. You can see the space here. And the 10 months treatment, you can see we almost close. We also achieve class 1 molar. We can crack the deep overjet and overbite, and we get enough space for the whole dentition alignment. 7 months post phase 1, you can see we get space here, just posterior to the second premolar. And also in the lower arch, we align the teeth much better. And for the phase 2, we have some IPR in the lower front teeth to correct the black triangle and align the teeth, make the indigitation perfectly. We can see the procedure, stage 2. You can see the progress of the patient. So it's almost finished. So this stage, it's like only 1.5 years. We almost finished the case. So from this full unit class 2, deep overjet, deep overbite, crowding, we can solve this kind of patient with SASGB just by distalization of the molar together with the mandibular position advancement. You can see the treatment outcome, symptomatic. So I will show you the last case. We are combined all this advantage together. The 33 years old female, you can see the lower facial third decreased lower facial third, deep overjet, deep overbite, severe crowding in the lower, and moderate crowding in the upper. And you can see the omega-shaped dental arch. And also we can see scissor spines in the right-hand side and also left-hand side here, in the premolar area. So it's a very severe case. What do we get? We get a full unit class 2 molar, deep overjet, deep overbite, curved speed, scissor spine crowding, and the patient refused any surgery. So this is the cephalometric reading. It's a low angle. You can see FMA and the cephalometric and the CBCT. And when we find the lack of a periodontal condition of the second molar and scissor spine here, you can see the lack of periodontal condition is because of the trauma. So our treatment goal will be align and leveling, achieve class 1 molar, retract the upper frontal teeth, and coordinate the dental arch, correct the scissor spine, reduce overjet and overbite, increase lower facial third, and improve the genio-labial fold because the patient is a low angle patient, like a horizontal patient growth pattern. So the genio-labial fold is deep. So we want to correct this situation. So how to achieve class 1 molar? So we can move the mandible forward. Together, we can distalize the upper molar a little bit. So we can achieve class 1 molar by these two methods together. So how can we align the teeth, align the upper dentition and retract the upper incisors? We can have some IPR in the frontal. We can have some expansion in the upper arch. We can also use the space get from the molar distalization to retract the frontal teeth. But the most complicated for the patient is the lower arch. Why? We count the patient will have 10 millimeter crowding in the lower arch. So if we want to distalization and the expansion together and with IPR, we need to distalize the lower molar like 3 to 4 millimeters. So if we want to distalize the lower molar 3 millimeter, it will be more complicated for us to distalize the upper molar because it's original full unit class 2 molar. And don't forget the patient's periodontal condition because of the trauma caused by scissor spines. So we has to skip this treatment plan. So finally, we decide to extract one incisor in lower. It will help us to align the teeth more efficiently. So the treatment plan will be use SASGB to move the mandible forward, and together we expand the dental arch, we coordinate the lower dental arch, we correct the scissors bite, we align the teeth, we align the lower teeth by the extraction of the one incisor, and we retract the upper incisor after the stage 1. So this is the treatment plan. So what can we get? You can see the first month, you can see an initial alignment. Also, the scissor spine has been corrected gradually. And we have some cross elastics in the buccal segment. You can see 12 months, what can we get? The scissors bite had been cracked. You can see the arch form has been coordinated much better, and also both for upper and lower. And after we deslice the upper and molar, we get space posterior to the second premolar, and we achieve class 1 molar. And if we open the deep overjet and overbite, and the scissors bite has been cracked. So this is what we get and what we designed. So it's quite similar. So it's after 12 months treatment, you can see the labial mantle fold has been improved a lot. So this is phase 2 treatment. We continue to settle down the occlusion, align the teeth, have some IPR to retract the frontal teeth, and close the space. You can see what we get. 18 months, 22 months, you can see get some space here. You can see the occlusion has been improved a lot. And 24 months, 26 months, we finished the case. It's perfectly. And you can see the smile and the facial profile. You can see lateral cephalometric and also the OPG. You can see the root parallel, and the periodontal condition has been improved a lot, especially for the scissors bite area. So before and after, you can see we elongate, we increase low facial third, so the patient looked younger, right? The labial mantle fold is very deep in the previous before treatment, but now it's much better. Before and after, the arch form has been improved a lot. Before and after, so you can see the condyle morphology has been changed a lot. The CBCT, and this is for 2 years for follow-up. It's very stable, and the periodontal condition has been improved a lot. And smile. So in summary, what is the advantage of a Smartee SA SGB? We can reposition the mandible. At the same time, we can correct the individual teeth simultaneously, including alignment, expansion, and desalization of the molar, and make the open bite in the back segment better. And we can correct severe jaw discrepancy without surgery or even without teeth extraction. And this kind of treatment is effective in adult patient therapy. You can see, I will show you many cases. Few patient is adolescent patient and young teenager patient. Almost every patient is adult patient and very stable. And we have used this kind of treatment, like more than 30,000 cases successfully treated in China now. So I think I've finished all my lecture. So if you guys have many questions, I'm glad to answer the questions. Okay.
Okay. Thank you very much, Dr. Xu, for your great presentation. I'm sure everyone from our heart will give you a warm round of applause. And now it's the time for question and answers. There are already several questions in the area, in the chat box and Q&A area. Let's go through them one by one. And for all of you online, if you have any questions, please feel free to type in your question in the chat box. So I'm sure each question will be addressed by Dr. Xu. So let's look at the first question. There's a question from Adelia Susanto. The question is, how long does it typically take to achieve a class 1 molar relationship from a full cusp class 2 using the S8 SGTP technique? Does this time frame vary between adults and growing patients?
Thank you for your question. And definitely, yes, the timing of the time is different because for the younger, for the growing patients, maybe we are used to SA, the advancement treatment like 8 months to 10 months. I think it's enough. And for adult patients, generally we are ask a patient to wear like 12 months to achieve a stable position of the mandible. And that one thing is very important is the patient should wear the appliance when they're eating, when they're chewing, when they're eating, you know. So if the patient just remove the appliance when they're eating, so it won't help to maintain the position of the mandible. So that's very important.
Okay. Thank you, Dr. Xu. I think you've already answered another question. Someone did ask whether the patient need to wear the device during eating. Okay, let's move on to the next question from Mr. Thomas. Is it necessary to wear the aligners in phase 1 also during eating, or they can be removed for the periods of eating and teeth brushing? I think you've already answered that question.
We strongly recommend the patient to wear this kind of appliance 24 hours a day. But when the patient wants to brush the teeth, okay, we can remove the appliance. But when the patient eating, chewing, and especially sleeping, so the patient should wear the appliance. So it's more persuading. It's most persuading for the adult patient because the adult patient refuse has surgery and they won't have some move the mandible forward. So there will be more complaints. Compliments to our treatment plan. Yeah. So next question is about, so how often we change the appliance? Okay, we are changing the appliance like 5 days to 7 days, like this kind of period, because the plastic, I mean the SASGB, we have a block in the posterior area. So the block is like very fragile. So it's like easy to like tear. So it cannot like last for 10 days to 2 weeks. So we sometimes in my clinic, I ask patient to change like every 5 days to 7 days. Yeah.
Okay. The next question is, what is the average time you suggest to wear each aligners with SGTB protocol?
Oh, I mean the changing period, like 5 days to 7 days. Yeah.
5 to 7 days.
Yeah.
Is it possible not to wear the aligners the whole time?
We strongly recommend the patient wear the whole time. Yeah. So it will help to maintain the stable position. It's a key. It's a key. So if the patient complains that, okay, I can't wear when I eating, while biting. So I will told the patient, oh, maybe we can't finish the stage 1. We can produce many more the aligner for you to wear until you can wear the whole day. Yeah. Can you remember the patient, the periodontal condition is so weak? So for generally, we can use aligner just to align the leveling the lower curve speed and intrude the lower frontal teeth and to elongate the posterior teeth by to correct the open by the frontal in the buccal area. But for that young gentleman, the periodontal condition is so weak, so we cannot intrude the lower frontal teeth with aligner. So we want to like close the open bite by elastics more efficiently and very quickly because we don't want any trauma in the frontal area. So we talk about with the patient, we change the braces and put the braces on, put the elastics, just 1 month. And I think I remember it's not like 2 weeks or 3 weeks, we can close the open bite gradually. So that's why I didn't use a aligner for the patient for the stage 2.
Okay, thank you. Next one, a question from Mohammed. How mandible were repositioned in adult patient? It's only dental alveolar movement.
No, we changed the morphology of the condyle. So the condyle can have potential to for the remodeling for the whole life. So because we don't have enough time to show you the whole lecture, the whole contents of our lecture. So in the last session, we are show you many CBCT image and MRI image and many evidence of the adult patient who will have some very strong and obvious remodeling of the condyle. So it's not just dental alveolar movement. It's we move the mandible forward. So it's a stable position of the mandible, and the key of the stable the 2 key of the stable is the occlusion should be very stable, and also the remodeling of the mandible of the condyle should be stable. So these 2 things make the treatment stable. Yeah.
Mm-hmm. Okay, thank you.
It's comfortable patient to it's not comfortable when the patient eat, but the patient don't have it other option, right? Or the patient will accept the surgery, or the patient will wear the appliance. But when the patient talk, it's okay. Generally, for my patient, it only take 2 weeks for them to adapt the appliance when they go to work to have some speech. Yeah, but if the patient is like a singer or like host, the TV guy, maybe you need to worry about that. Yeah, for generally speaking, I think just 2 weeks they can adapt the speaking the speaking way. Yeah. I know them. Yeah, if it's too big and the patient can't move the mandible forward that much, I think if in my clinic, I will not ask patient to achieve edge-to-edge relationship. Maybe I can achieve like cusp-to-cusp molar relationship and have some some distalization of the molar. Because if you want to move the mandible too much forward, the condyle is out of the fossa. It won't be stable. Yeah, so I won't move the mandible forward like step by step. So in my opinion, the maximum of the sagittal movement of the condyle is like 4 millimeter to 5 millimeter. The max, the quantity of the sagittal movement. So if you want to like move the mandible forward like 12 millimeter, I think it's impossible to make a stable outcome. So sometimes we need to like negotiate with the patient. Maybe sometimes we can move a little bit and retract, distalize a little bit. Yeah. What is the distalization protocol? Did you extract? Yeah, of course. If you want to distalize the molar, we need to extract the 3rd molar first, and we will distalize 1 by 1. Yeah, it's very unique for the SASGTB. So like for upper dental arch, we will distalize the 2nd premolar, second molar first, and when the finish of the distalization of 2nd molar, we distalize the digitalize the first molar, and we stop. We stop. We want to digitalize the second premolar as a stage 1. And we don't need anchorage for the upper digitalization. But that's very important. But if we want to digitalize the lower dentition, we need anchorage. So the protocol will be we digitalize the lower second molar first. And after we finish the digitalization of the second molar, we put mini screw between second and first molar in the lower, and put some rubber band and put some elastics, help to help to strong the anchorage, and then we digitalize the lower lower molar. Yeah, so that's very important. The anchorage protection is very important. Yeah. Do you know why extrude, if you use a liner to extrude the positives, it's quite challenging? It's because of the biting force is too strong. If you want to extrude the positives, but the biting force will help to is cause a relapsing force. So you can see when we after finish the stage 1, it's open bite in the posterior area. So it's open bite, so no relapsing force. So we can extrude the positives more efficiently. So for most of the patients, in the past, we have put some lingual button, have some elastics to help to the eruption of the positives. But now, for most of my patients, we just need to align the teeth, use attachment to extrude the positives. That's enough. Yeah, because we don't have the biting force. No, we don't digitalize the molar to achieve the class 1 molar. Sometimes we use mandible more the move the mandible forward together with the digitalization. For some case, we count the how many millimeter we want to digitalize up and lower. So for example, if it's like a full unit class 2 molar relationship, we get 6 millimeter, right? Discrepancy want to achieve class 2 to class 1. So if I move the mandible forward 4 millimeter, so I only need to digitalize the upper molar 2 millimeter. So it come together to achieve class 1. You mean restart the treatment? Yeah, we can restart treatment. Yeah, for most of the time, we won't change the appliance from a clear aligner to fixed appliance. Is for most of the time. But if the patient want to change the appliance because he don't want to wear a liner for many reasons, maybe we can change. Yeah.
You take impression or scan edge
No,
to
that's
edge.
another question. It's about how to make the bite registration, right? So it's not in our topic today. So it's not edge to edge for every case. We need to achieve a perfect facial profile. So that's my key. That's my rule to do the bite registration, not just edge to edge. Yeah. So it's like more. We will share more information maybe in the next session. Yes, yes. The digitalization protocol is, yeah, you get it. Yeah. You know why? Because the block, we have a block attached to the aligner. So if we want to digitalize the second molar, a second premolar, so the block will like move more forward, but it's not enough, not stable enough, not strong enough to maintain the to when the patient use wear aligner to biting and eating, it's not strong enough. Yeah. So we will stop. Yeah. Oh, we have more questions. How long?
More questions coming.
Generally for adult patient is like 12 months. 12 months, I think, is enough. Yeah, if the patient can wear the appliance, the SASGB when she or he eating, 12 months is enough. Is stable. How do you take records in the SGB protocol? How to take the next session? Yeah. You mean the bite registration? Yeah, in the next session. Yeah.
Oh, there's one more question in the chat box. Do you intrude the upper molars by distalizing also?
For most of my patients, no, I won't do that. I just distalize the molar, and because when we do the bite jumping, we move the mandible forward. It's open bite in the buccal segment. So for most of the time, we want to more stable outcome of the mandible position. So we want to help the interdigitation. We want to make the molar contact. So we don't intrude the molar. But there's one case in my gallery. It's like a very high angle case, and I want to move the mandible forward. Together, I want to clockwise rotate the mandible, or counterclockwise rotate the mandible. So for that case, I intrude the molar. Yeah, just one case. Yeah.
Why can't we distalize the second molar 50% and then start distalizing the first molar together with the second molar?
Yeah, it's like a routine protocol of the aligner. Yeah, but if you use this protocol in the upper, because the aligner, the material for the aligner for the phase 1 is like more rigid. So, and we have 1 year, the whole year we can do the distalization. So we don't need we like don't want the off track of the treatment. So I recommend to move to distalize the molar one by one. You know, so we don't want any off track. But for the lower arch, that's because of the anchorage need. If you want to distalize the second molar together with the first molar, it won't provide enough anchorage for lower dentition. So I recommend to move the second molar at the end position and put mid screw and move the first molar. Yeah.
Okay. Seems your answers have inspired more questions. There's one more here. How about relapse rate and retention protocol?
So if the patient don't wear the appliance when he or she eating, so the relapse will happen. And if you don't make the occlusion stable, the relapse will happen. So that's important. The patient will make the position, mandible position, forward position at any moment when the patient eating, biting, speaking, and sleeping at every time, 24 hours a day. Yeah, so that's important. Yeah. So if you, from after the phase 1, so for most of the dentists or orthodontists, we are afraid after phase 1, because the occlusion is not so stable, it will relapse. You can put some class 2 elastics, yeah, to help to do the retention. Yeah.
I'm sure all the questions have been answered. If you have more questions, we can leave it to our next session. And so today, I think all of you will join me to thank Dr. Xu for his excellent speech. And I will also thank you for joining us during this webinar. I hope you will find today's session will be insightful and helpful to your clinic practice. So before we finish today, I'd like just to take one more minute to take you through to the Smartee Academy webinar program that has been planned for the rest of November and December. So you will have some ideas about what are the topics we will cover in the next 2 months. So just 1 minute, let me share my screen. So as you can see, there will be 3 more sessions planned in November, and 1 more session has already been planned in December. Just now, we had a question from one of the attendees today asking for the whether we will be a session about wax registration. Certainly, if it's an area you are interested, that can also be planned for our future sessions. So just please just follow us on our Facebook, LinkedIn, or the social media, so you can get the most updated information about all the future sessions. So I think that's all for today. As that concludes our today's webinar. Once again, I'd like to thank the speakers, Dr. Xu, and also thank you for taking your time today, and also thank you for your continuous support for Smartee. So everyone, now today's session is completed. Please enjoy the rest of your day, and we look forward to see you in our future sessions. Thank you. Goodbye, everyone.
Goodbye. Thank you. Thank you for
Bye.
attention.